You are lying on the ground. The back of your head is resting on a folded animal hide. Two people are holding your shoulders down. A third is kneeling beside you, and in their hand is a sharpened piece of obsidian, dark and translucent, with an edge sharper than any steel scalpel that will be invented for another 6,000 years. They press the edge against your forehead, just above the hairline, and they begin to cut. You are fully awake. There is no anesthesia. There is no sterile operating room. There is no medical degree hanging on a wall. There is a person with a stone tool cutting a hole in your skull while you feel every single thing that is happening. And here is the part that will keep you up tonight. This was not murder. This was not punishment. This was not ritual sacrifice. This was surgery, and the patient survived. Not sometimes, often. In some populations, more than 80% of the time. Humans have been deliberately cutting holes in living skulls for at least 7,000 years, possibly longer, across every inhabited continent, using techniques so refined that the survival rates improved century over century. This is not primitive butchery performed by people who did not know what they were doing. This is evidence of something much harder to explain. Ancient humans were performing neurosurgery with stone tools, and they were getting better at it. The story begins in 1867 in the office of a French physician named Paul Broca. Broca is one of the most important figures in the history of neuroscience, though not for the reason he is relevant here. In 1861, Broca had identified a region of the left frontal lobe responsible for speech production, now called Broca's area, by studying a patient who could understand language but could not produce it. That discovery was foundational. It established, for the first time in modern science, that specific cognitive functions are localized to specific brain regions. 6 years later, an American diplomat and archaeologist named Ephraim George Squeer walked into Broca's office carrying something in a wooden box. It was a human skull from a pre-Columbian burial site in Cuzco, Peru. The skull had a rectangular hole cut in it. The edges of the hole were smooth, rounded, and showed unmistakable evidence of new bone growth. Bone regrowth at the margins of a wound is the body's healing response. It takes weeks to begin and months to complete, which meant this hole was not the cause of death. It was a wound the person had survived. Someone had deliberately cut a piece of this person's skull away, and the person had lived long enough for the bone to start healing. Broca examined the skull and confirmed what Squeer suspected. This was not damage. This was not an accident. This was an intentional surgical procedure performed on a living human being. Broca called it trepanation, from the Greek trepanon, meaning borer, and in the decades that followed, as archaeologists began looking for it, they found it everywhere. Trepanned skulls have been recovered from Neolithic sites across France, Spain, Portugal, Austria, Germany, Russia, and Scandinavia. They have been found in ancient China, in sub-Saharan Africa, in the Middle East, in Mesoamerica. The oldest confirmed trepanation in Europe, found at the site of Ensisheim in the Alsace region of France, dates to roughly 5,100 BCE. The skull belongs to a man approximately 50 years of age, who had two separate trepanation holes, both fully healed with smooth remodeled margins, meaning he survived both procedures and lived for years afterward. But the highest concentration of trepanned skulls on Earth comes from ancient Peru, and the numbers are staggering. The bioarchaeologist John Verano at Tulane University has spent decades studying Peruvian trepanation and has documented over 800 trepanned skulls from pre-Columbian Andean cultures spanning roughly 2,000 years. 800 from a single region. This was not a rare, desperate procedure. It was a routine medical practice, performed by specialists, on a scale that has no parallel anywhere else in the ancient world. And the techniques were not crude. 4 distinct methods of trepanation have been identified in the archaeological record. The first is scraping. Using an abrasive stone tool, the surgeon gradually wore through the outer table of the skull, then the spongy diplo layer, then the inner table, creating a shallow, smoothly excavated opening. This was the most common technique in Peru and probably the safest because it was the slowest and gave the surgeon maximum control. A scraping trepanation might take 30 to 60 minutes of continuous work. The second is grooving. The surgeon used a sharp flint or obsidian blade to cut 4 intersecting lines into the skull, forming a square or rectangle, then pried out the resulting bone fragment. This was faster than scraping but required a precise understanding of skull thickness to avoid plunging the blade into the brain beneath. The third is boring. Small circular holes were drilled in a ring pattern close together, using a pointed stone tool rotated between the palms or driven by a bow drill. Once the ring of holes was complete, the bridges of bone between them were cut or broken, and the central disc was lifted out. This technique is common in European Neolithic trepanations, and shares a mechanical principle with modern surgical trephines. The fourth is linear cutting. A sharp blade was used to incise a circular or oval groove directly into the skull, deepening it pass by pass until the bone disc was free. This required the steadiest hand and the sharpest tool, and it appears most frequently in later, more technically advanced populations. If you are watching this and it is reshaping what you thought ancient people were capable of, subscribe to Footprint Zero. We do this every week. Now here is the question that changes this from a curiosity into something genuinely profound. Why? Why would anyone voluntarily allow someone to cut a hole in their skull with a stone tool? The romantic answer is ritual, releasing evil spirits, treating madness, and there is almost certainly a spiritual dimension to some trepanations. But the most compelling explanation, and the one supported by the strongest physical evidence, is far more practical: head trauma. A blow to the head from a fall, a rock, a club, or an animal can produce what modern neurosurgery calls a depressed skull fracture, where a fragment of bone is driven inward toward the brain. That fragment presses on the brain tissue beneath it, producing swelling, impaired function, seizures, loss of consciousness, and frequently death. Many trepanned skulls from Peru and Europe show evidence of blunt force trauma in the immediate vicinity of the trepanation site. The hole was not random. It was placed directly over the injury. And here is where this connects to a principle in modern neuroscience that explains why the procedure actually works. The Monro-Kelly doctrine, named for the Scottish anatomists Alexander Monro and George Kelly, who described it in the late 18th century, states that the cranial vault is a rigid, fixed-volume container. The brain, the cerebrospinal fluid, and the blood within the skull exist in a constant volume equilibrium. If anything is added to the system, a blood clot from a ruptured vessel, swelling from an injury, fluid from an infection, the pressure inside the skull rises because the bone cannot expand. That rising pressure is called intracranial hypertension, and if it is not relieved, it compresses the brain, cuts off blood supply, and kills the patient. A trepanation hole relieves that pressure immediately. By removing a section of skull, the surgeon gives the swelling somewhere to go. The pressure drops. Blood flow to the brain is restored. The patient, who may have been comatose or seizing, can recover. This is not ancient magic. This is the exact principle behind modern emergency burr hole surgery, a procedure performed in trauma centers today when a patient presents with an epidural hematoma or subdural hematoma and is deteriorating rapidly. The neurosurgeon drills a hole in the skull, evacuates the collected blood, and the patient's neurological function returns, sometimes within minutes. Ancient trepanation surgeons did not know the Monro-Kelly doctrine. They did not have a theory of intracranial pressure, but they had something equally powerful. They had observation. They had seen what happened when someone took a blow to the head. They had watched the progression from impact to confusion to seizure to death. And at some point, someone made the connection that opening the skull after a head injury could reverse the decline. Not because they understood the physics, because they had watched it work. And then they refined it. This is the part of the story that John Verano's research makes undeniable. In the earliest Peruvian trepanations, dating to roughly 400 BCE, the survival rate was low, roughly 40%. Many patients died during or shortly after the procedure, as evidenced by trepanation holes with no bone regrowth at the margins. But over the following centuries, as the practice was repeated, refined, and presumably taught from practitioner to apprentice, the survival rate climbed. By the time of the Inca Empire in the 15th and 16th centuries, survival rates for trepanation had reached between 75 and 83%. Think about what that trajectory means. This is not luck. This is not random variation. This is a measurable, statistically significant improvement in surgical outcomes over roughly 2,000 years in a population without writing, without formal medical schools, without germ theory, without anesthesia, without any of the infrastructure we associate with medicine. The improvement came from accumulated experience, passed from generation to generation, refined by observation and repetition. Someone was teaching this. Someone was learning it. Someone was remembering what worked and discarding what did not. That is a medical tradition. That is a curriculum. That is knowledge in motion across centuries. If this has changed how you think about what ancient people understood, hit the like button. It helps more people find this. Now, the survival rate also raises an uncomfortable question. How did anyone endure this procedure? The skull itself has no pain receptors. The brain has no pain receptors. This is why modern neurosurgery can be performed on a conscious patient, but the scalp does. The periosteum, the thin membrane covering the outer surface of the skull, is extremely pain sensitive. and cutting through the scalp to reach the skull would have produced intense, sustained pain. In Peru, the most likely candidate for pain management is the coca leaf. The coca plant, Erythroxylum coca, is native to the Andean region and has been cultivated and used by indigenous populations for at least 8,000 years. Coca leaves contain the alkaloid cocaine, which is a potent local anesthetic. When coca leaves are chewed with an alkaline substance like lime ash, which was standard practice, the cocaine is released and absorbed through the oral mucosa, producing numbness in the mouth and throat. Applied directly to a wound or incision site, coca leaf preparations would have provided meaningful local anesthesia. There is no direct archaeological proof that coca was used during trepanation procedures, but the overlap is striking. The same cultures that performed trepanation at the highest rates in the world also had the most extensive knowledge of coca pharmacology. The tools were in the same hands. In European and African contexts, where coca was not available, other botanical analgesics may have played a role. Alcohol, produced by fermenting fruits or grains, has been used as an analgesic and sedative across cultures for millennia. Willow bark, containing salicin, the precursor to aspirin, is native to Europe and would have provided some anti-inflammatory and pain-reducing effect. Opium, derived from the poppy Papaver somniferum, was known in the Eastern Mediterranean by at least the late Neolithic period. Whether any of these were used specifically during trepanation is unknown, but the pharmacological toolkit existed. There is one more dimension to this that most accounts overlook entirely, and it has to do with what happened to the piece of bone that was removed. In many archaeological contexts, the bone disc, called a rondelle, was not discarded, it was kept. At Neolithic sites across France, rondelles have been found with holes drilled through them, clearly prepared to be worn on a cord as a pendant or amulet. Some have been found in burials, placed on or near the body of the deceased. At the site of Saint-Germain-la-Rivière, in the Gironde department of France, a rondelle was recovered from a burial context with wear marks consistent with years of handling. A piece of a living person's skull removed during a procedure that the person survived was being carried, worn, possibly venerated. This is not a medical waste product. This is a sacred object, a piece of someone's head that they no longer need, removed by a procedure that should have killed them but did not. The rondelles tell us something that the trepanation holes alone do not. They tell us that this procedure carried meaning beyond the medical, that surviving it conferred something, status, spiritual power, protection, that the bone fragment itself was proof of having crossed a threshold that most people would never approach, and returning. Go back to the person on the ground, the one with the obsidian blade pressing against their skull, the one who is awake and can feel everything. They are terrified. Of course they are, but they are also choosing this, or someone who loves them is choosing it for them, because the alternative is worse. The alternative is the swelling that will not stop, the seizures that are getting closer together, the slow slide into unconsciousness from which there is no return. And the person kneeling beside them, the one holding the blade, is not guessing. They are not experimenting. They learned this from someone who learned it from someone who learned it from someone. They know where to cut. They know how deep. They know what the bone sounds like when they are almost through. They know what the membrane beneath it looks like when they should stop. They have done this before, and the last person they did it to is still alive. That is not primitive. That is not barbaric. That is a human being, armed with a stone and centuries of accumulated knowledge, performing the oldest known surgery in human history, with a success rate that would not be meaningfully surpassed until the invention of antiseptic technique in the 19th century. The next time someone tells you that ancient humans were simple, that they lacked sophistication, that real medicine began with the Greeks, or the Egyptians, or the scientific revolution, remember this. Thousands of years before anyone wrote down a single word about the human body, someone picked up a sharpened stone, placed it against the skull of a person they were trying to save, and cut. And it worked. We covered ancient pain management and survival in our video on how ancient humans survived a broken leg, and the care networks that made these kinds of procedures possible go even deeper than most people realize. That one is worth watching next.